Okay, my name is Hironori Kaneko. Let me start it. First of all, welcome to the ELS 2021. First of all, I'd like to congratulate on a fabulous virtual meeting. David Guerra, you have a great job. And it is honor for me to moderate the first session titled Laparoscopic Liver Resection for Hepatocellular Carcinoma. We have three distinguished speakers. Due to the time limitation, we will skip each introduction. And the first speaker is Hoso Han. He will talk about the laparoscopic liver dissection for hepatocellular carcinoma in liver cirrhosis. So, Hoso Han, why don't you go ahead?
I think that I have submitted some video. Would you please start the video? Good day, dear friends and colleagues. It is a great honor for me to speak in this Third World Congress of International Laparoscopic Liver Society. First of all, I'd like to appreciate Professor David Geller for inviting me to this Congress, and I also appreciate program chair, Dr. Horacio Asman and Dr. Claudius Conrad. Today I speak about laparoscopic liver dissection for HCC in cirrhosis. I have no conflict of interest. I will speak about, is it all right to perform lap liver dissection in cirrhosis as a first topic. Then I speak about, what about outcome? Then I speak about lastly, is there a useful technique for cirrhosis? First, I speak, is it all right to perform lap liver dissection in cirrhosis? As you know, the liver is very cirrhotic. The operation is difficult. This is the review article from our center. The title is similar between this speech, lap liver dissection for HCC in patient with cirrhosis. The problem of cirrhosis is that this cirrhosis is a risk factor for developing postoperative morbidity. There may be severe blood loss and prolonged ascites after major hepatectomy. These complications may prolong postoperative hospital stay and may cause hepatic failure. Lap liver dissection has a possible advantage in cirrhosis. This surgery may minimize the reduction in collateral and lymphatic flow, which is caused by laparotomy open surgery. And lap liver dissection may reduce compressive mesenchymal injury, and by this, there may be a possibility of lower instance of postoperative liver failure and ascites by minimal invasiveness. I speak about the minimal, less liver failure, less in the speech. This is the study of lap liver dissection for hepatitis-related HCC in patient with child B or C cirrhosis. Between 2004 to 2013, 232 patients has been performed with lap liver dissection. 141 patients has pathologically proven cirrhosis. Among them, 13 patients had child B cirrhosis and 3 patients had child C cirrhosis. Median operation time was 215 minutes. Median estimated blood loss was 350 milliliter, and the median hospital stay was 8 days. There was no postoperative mortality in the operation, and median follow-up period was 51.6 months. When you look at the survival curve of child B or C patient, left side is overall survival, right side is disease-free survival. Overall survival is around 80%, and disease-free survival is around 40%. Is encouraging outcome. There are recently important paper article of child PUB cirrhosis. Dr. Robert Troisi, the next speaker, will speak about this in detail. I briefly talk about this. 253 patients with child PUB score has been accumulated. About this whole patient, 47 patients is a recent series, so more and more patient is performed by laparoscopy in recent cases. If you look at complication, in major hepatectomy, minimal invasive surgery is only 5 patients, so it's very difficult to compare. But in minor hepatectomy, when you compare open and minimal invasive surgery, morbidity is 46% open surgery and 30% minimal invasive surgery, less morbidity. Child Clavin-Dindo classification 3-4, 40% in open, 25% in minimal invasive surgery. So Clavin-Dindo more than 3 is less in minimal invasive surgery. About ascites, minimal invasive surgery group has less ascites. Therefore, you can see there are advantages of laparoscopy in cirrhotic patient. This is a nomogram. I think Dr. Troisi will speak about this later. About this article, liver resection for HCC in child PUB cirrhosis can be considered after careful patient selection. Patient characteristic, tumor pattern, liver function, and surgical approach should be considered as a selection criteria. I'll speak about next topic. What about outcome? We have reported on liver resection for hepatocellular carcinoma in cirrhotic patient. This study is a 10-year single center experience. 141 patients has a cirrhosis, 91 patients non-cirrhosis. When you compare survival versus non-cirrhotic versus cirrhotic patient, overall survival is similar between non-cirrhotic versus cirrhotic patient. But in disease-free survival, the green line is a cirrhotic patient. Green line, cirrhotic patient has poor recurrence-free survival, disease-free survival compared to non-cirrhotic patient. So we are wondering why cirrhotic patient has high recurrence. Why? We have hypothesized that the thrombocytopenia, platelet number may be a factor for recurrence. Therefore, we have studied our patient. There may be many predictive factors for recurrence, including child class, albumin, bilirubin, AST, ALT, INR. This whole factor has no significance for recurrence. Only platelet is the significant factor for recurrence in univariate analysis and multivariate analysis. We stratified the level of thrombocytopenia. When thrombocytopenia is severe, less than 50,000, recurrence is high. When platelet level become normal, the recurrence rate decrease until 30%. But interestingly, thrombocytosis, 100% recurrence. So there are many articles that show that thrombocytosis is the recurrence factor. But actually, in addition to thrombocytosis, thrombocytopenia is the factor for recurrence. If you look at right graph, green line is the normal thrombocyte. Blue line is thrombocytopenia patient. The patient with thrombocytopenia has a high recurrence. I show another article. This is the laparoscopy versus open liver resection for hepatocellular carcinoma. This is a case-matched study with the propensity matching. If you look at the complication, liver resection has 12.5% complication compared to 20% in open liver resection. Complication is less in laparoscopic group. If you look at whole complication, liver failure is 3.4% in laparoscopy compared to 8-9% in open surgery. So liver resection group has a lower instance of liver failure. I speak about is there a useful technique for cirrhosis? Pringle maneuver is very useful for laparoscopic surgery. Cirrhotic patient there is bleeding, so Pringle maneuver may decrease the bleeding amount. Also, intercostal trocar is useful when the tumor is segment 7 and 8. Anatomy section is better for balloon preservation, and Gleason pedicle approach is very useful for laparoscopic anatomy liver dissection. Recently, vessel sealing device is good for the bleeding control, and the image is much better by 3D image and 4K image. Liver dissection will be the main treatment method of HCC, even with the liver cirrhosis. Thank you very much for your kind attention.
Thank you very much, Professor Han. And maybe data we will
everybody.
discuss. So
I thank Dr. Geller, Hasbun, and Claudius Conrad for organizing this ILLS 2021 meeting. My topic will focus on laparoscopic liver resection for HCC in child B cirrhotics. As you know, if for child A, there is for sure an indication for cirrhosis in selected patients, and this is also according to EASL or ASLD guidelines, whereas for child C, most likely liver transplantation is the solution if some important characteristics are respected. The treatment allocation for intermediate child B cirrhosis is still difficult and controversial because we are dealing with patient having a different degree of liver dysfunction. We can have the presence of portal hypertension or clinically significant portal hypertension, and also the extent of parenchymal resection, which depends on the tumor locations and relationship with the main intrahepatic vessels, is very important in the decisional algorithm. We know that there are some multivariable models of decisional algorithm proposed for predicting liver failure and mortality after HCC resection. Unfortunately, these models are not retained in the EASL or AASLD guidelines. And in the past lesson, we also observed that liver surgery for HCC on child B cirrhosis has been reported as an alternative to liver transplantation with acceptable mid and long-term results. We know also, and there is more and more evidence, especially in the last years, that minimally invasive surgery for HCC is a terrific asset. This is a very interesting multi-centric French study to predict the risk of symptomatic liver failure in patients with cirrhosis undergoing hepatectomy. And they found in the preoperative model three simple variables influencing the outcomes. And these are the intended laparoscopic liver resection, the residual total liver volume, and the platelet count as a surrogate marker of portal hypertension. And another recent study on more than 80 patients is also focusing on the significance of the laparoscopic approach in patients with portal hypertension. And the authors found that the laparoscopic approach, which was done in this series in 34% of cases, is responsible or is a predictor of decreased risk of postoperative liver failure and gaining of textbook outcomes. The textbook outcomes are depicted here. So means that no preoperative transfusion, no major complications, no 3 months mortality, and short hospital stay below 50 percentile, R0 resection, and no readmission. So this is a second evidence that is stressing the role and the benefit of a laparoscopic approach for HCC in specific clinical conditions. We were also, we aimed to found a nomogram on a predictive value of survival, tumor recurrence, and morbidity in childbirth B cirrhosis. This is a study which was conducted on 14 international centers with data coming from 14 international liver centers. We found 253 patients having child-pugh B class who underwent open or laparoscopic liver resection, and in most of the cases you see they were child B classified as child B7, and the complexity of this formula was translated into an application which is available online to predict morbidity and survival. And we based this prediction on 8 preoperative variables as presence or not of comorbidity, the child-pugh classification, the level of preoperative hemoglobin, and the preoperative platelets, presence of ascites, portal hypertension, the type of approach, open versus minimal invasive, and the type of hepatectomy, major or minor resections. So as you can see, in most of the cases, minor hepatectomy were performed, and there were a difference between open and minimal invasive approach in terms of less complications as 3-5 according to Claviandindo, less ascites decompensation, and less bleeding. However, when we looked to major hepatectomy, which were a minority, so only 15% of cases open or lap, we found no difference. So probably the extent of hepatectomy, especially extent of hepatectomy, is the most important factor in predicting the outcomes. There was just a slight trend to a shorter hospital stay if the patients were operated with a minimal invasive approach. To deepen these results, we gathered more data from 17 centers to have a one-to-one propensity score match on 17 predefined variables. So we got a total of more than 350 patients. You can see in the open group, there were 222, in the laparoscopic group, 160. These are the baseline characteristics before the propensity score match. So there were, of course, differences in sex ratio, in child-pugh rate, in platelet count, presence of preoperative viruses, and portal hypertension. But after propensity score match, we equalized these differences. So there were no difference at all between the groups, and this was concerning 100 open cases versus 100 laparoscopic cases. Looking to the operative details before the propensity score match, we found differences in position of the lesion, in the lesion sites, the year of operation, type of hepatectomy, type of resection, and need for cranial maneuver. After propensity score match, also these intraoperative of clinical parameters, operative parameters were equalized, so no difference at all between both groups. And when we look into the postoperative outcomes, we found that minimal invasive surgical approach to child B patient having HCC led to significant decrease in 90-day morbidity, less complication, especially ascites leak, And also there was a trend to reduce the hospital stay. However, this was not statistically significant. And when we look to the overall and disease-free survival, 5 years overall survival was 65%, and the disease-free survival was 37% for laparoscopic group versus 47 and 32% for the open group. To deepen the clinical significance of this, our Kaplan-Meier analysis, we conducted the restricted mean survival time analysis, which show finally that laparoscopic group survive 631 years longer than those in the open group when patients are followed up to 7.3 years. And of course, we did not find any statistical significance between both groups. So we conclude that minimal invasive surgery for HCC and cirrhosis is nowadays a fundamental approach, whenever feasible, to decrease not only the postoperative liver failure, but also the overall morbidity. Laparoscopic resection in child PIB patients is doable in well-selected patients. Liver failure and ascites productions were very low compared with rates for open resection. We noticed the relatively worst results in B9 patient. Maybe this could be related to the presence of more enhanced portal hypertension. Best candidates are patients with fewer smaller lesions, tumor distant from major vessels, eventually partial resection in anterolateral segments. There are some recent decisional algorithms which are capable to predict outcomes and are also available online. And finally, unexpected intraoperative variables, technical issues and skills potentially altering the predictive models of these very delicate patients. So we should pay a lot of attention when selecting child B patients for liver surgery. And I thank you for your attention, and we all, the Italian group, is eager to host ILLS 2023 in Rome. Thank you so much.